and she'll be leading today's session. The session's a mix of PowerPoint and some practical hands-on using our seating to demonstrate some of the clinical learning that we're going to get with Rebecca. So if I leave Rebecca, wander off to start to load that presentation. Before we start, if we can just discuss some housekeeping. The session is being recorded, so please make sure your mics and your cameras are switched off. If we have any technical issues, if you'd like to post that in the chat feature, my colleague Jess, who's also helping us today, will try to help on that technical issue. What we tend to find works best, though, is just to leave the meeting and rejoin. For some magical reason, it just seems to reset everything and things tend to go a lot better if that happens. After the session, we'll be posting out to you a copy of the presentation, plus a link to the a recording of the presentation. So if you have colleagues who can't be with you today, they can always watch the presentation whenever it's more convenient for them. So I'm just going to pass you over to Rebecca.
Thank you, Les.
And I shall catch up with you in about 20 minutes or so. Thank you.
Give that time to load, and hopefully that's now on everyone's screens. And as Les said, what we're going to do is run through some theory around postural care, how special seating plays a role within, and how we can apply it to care home settings. And then we will have a look at the seating solutions in a bit more detail and apply some of that theoretical knowledge to see how it can actually improve working practices within care homes. And my understanding is that we have a mix of different professionals and specialities joining us today from lots of different settings, from complex disabilities, neuro rehab, through to elderly care and to specialist dementia care. We don't have much time with you. So we'll try and get through what we can through the presentation. Anything additional we will send out afterwards with a bit more detail. If there's anything specific that you hear me talking about that you want to know about, use the chat function and Jess will be able to guide you there. Okay, so let's just set the scene then. Now, those of you have joined us today because you work in care home settings, and undoubtedly you do what you do because you want to promote the best quality of life possible for the individuals that you work with. Now, understanding and appreciating the importance of postural care, and specifically good sitting posture, can support that objectives, but it can also help you work in practices too. Now, when we think about the types of individuals that you might work with in these care home settings, thinking about the neurological and neuromuscular conditions, Huntington's disease, multiple sclerosis, motor neuron disease, stroke, Parkinson's disease, moving on then to complex disabilities, those of you who might work with learning disabilities or intellectual disabilities, cerebral palsy, acquired or traumatic brain injuries, spinal injuries, chromosomal disorders, if you work with Rett syndrome, Down syndrome, and even those on the autism spectrum disorder and some of the challenges that they can experience. Now, what we have to remember is this holistic approach. So yeah, knowing somebody's diagnosis can be helpful in terms of understanding maybe the path of that diagnosis and the prognosis to help with long-term planning. But ultimately, when it comes to postural care, that holistic approach, looking at the individual in front of us, doing the postural assessment and coming up with those postural challenges. Now, what can happen? Yeah, but even within stroke itself, as we know, two individuals won't present with the same symptoms or the same signs. So even between diagnoses, there's going to be a difference in how the individual presents. But what there might be some overlapping postural challenges that we might come across when working with complex disabilities, neuromuscular, neurological conditions. So in terms of this holistic approach, rather than focusing on the diagnosis, we're just considering the person sitting in front of us. Having a look at how they present and then addressing that through the seating solution. So some of the things we might see commonly with those who do present with these type of diagnoses, things like pain and discomfort, Fatigue, so there could be energy management concerns, energy conservation, getting tired quickly within the chair, or with any posture that they adopt. And what happens here is those body segments tend to work inefficiently. They don't work very well together, and that's why individuals fatigue quickly within the chair, especially with the effects of gravity as well, because it's unrelenting. So to be able to remain erect, that rigidity against gravity can be really difficult for individuals who experience those energy conservation problems. We might see individuals with postural instability and lack of postural control, which then can present itself as pelvic instability. We might see involuntary movements. So from Huntington's disease with those choreic, quite violent, severe movements through to ataxic movements that we might see in MS, or even through to extensor thrust patterns that we could see in cerebral palsy. Tonal changes, whether that's high tone or low tone. We might work with individuals who have spasticity, and the pain that could be associated with that, and obviously the long-term risks associated with contractures and deformities. Muscle weakness and paralysis, especially with asymmetries as well, so differences on the left to the right side of the body. Sensory impairments can make it really difficult as well for individuals to achieve their optimum sitting posture, not only visually and the vestibular system, but proprioceptive as well. That proprioceptive feedback is really key for people to have postural stability within the chair. And then impaired cognitive function can affect their ability to know then about their awareness around needing to change position, how to do that safely, transferring in and out of chairs. So that's another challenge that we might need to address when working with these types of individuals. So what I wanted to do was just run through some of the most common postural challenges that we might see out in the field. I don't know if you would agree, but a posterior pelvic tilt is probably one of the most common that we see. That sacral sitting, the pelvis tilts backwards, and you see the individual sliding down the chair. And the problem with the posterior pelvic tilt is it can be associated with other significant postural challenges. So what we might see, you can see in the image there, somebody also presenting with that increased thoracic kyphosis, that curvature at the top part of the spine. That then can lead to a hyperextension of the neck because they're trying to maintain that visual field rather than looking down at the floor. What we need to do with any form of postural assessment is find out the intrinsic and extrinsic causes. We have lots of webinars, as we mentioned, we've got lots of resources. So if anything you wanted to know about in more detail, pop it in the chat and we can send it through. We've got a YouTube channel with lots of educational short videos around objective assessment and so on. And then webinars specifically on these postural challenges in a bit more detail on the website as well. But anything that I mentioned, you want a bit more information on, pop in the chat, as I said, and just be able to follow that up. But what we need to do is find out those intrinsic and extrinsic causes to really know what the limitations are of those body segments. Because ultimately the question we're trying to ask ourselves when it comes to specialist seating is, can I correct this body segment, or do I need to accommodate it? And it's really key that that postural assessment is determined before you do the seating assessment. So if you do contact CareFlex to do that joint seating assessment with us, you already have that postural challenge list, and then you work together with the seating assessor to come up with a solution. Because what can cause this posterior pelvic tilt intrinsically, when we're thinking about the type of individuals we work with maybe it's that neurological involvement. It could be them being pulled down, tonal changes, being pulled into that position. Thinking about dementia care or frailty, generalized weakness, the abdominal muscles, and they've fallen into that position because they lack the ability to remain erect against gravity. What then can happen, if you can see in that image there, increased pressure going through the sacrum, going through the apex of that thoracic spine, and even through the heels. Next, we have an anterior pelvic tilt. Now, this is where it tilts anterior, so the pelvis tilts forward, and the bony prominences at the front become lower than the bony prominences at the back. What can happen with an anterior pelvic tilt, what we might do is see with individuals with that extensor thrust going into that position because of those tonal and reflex changes. What can happen then is they have this reduced functional reach because of the positioning of the body segments. We could have that increased lumbar lordosis and the pain that could be associated with that. We could have intrinsic causes from tight hip flexors, Maybe it's an individual, if you're working with bariatric individuals, a plus size population, sometimes they go into this position for comfort reasons, just to relieve pressure on the abdomen. So again, being mindful of that correction or the accommodating, because if we try and correct that posture, it could then cause even more discomfort for them. So knowing those intrinsic and extrinsic causes are really important. Then we have a pelvic obliquity. So this is where one side of the pelvis is higher than the other side. Often, but not always, associated with a pelvic rotation, which we'll cover next. What then can happen, because the pelvis is the foundation for good sitting posture, dictates what happens to the body segments and below. If we have that pelvic obliquity, we could then have the asymmetrical trunk position as well, as the individual tries to compensate by getting the head back to midline. And if unmanaged, it could then develop that scoliosis. And again, we'll cover that shortly. We might see individuals with that abnormal muscle tone, whether that's high or low tone, being pulled or falling into that lateral flexion. It could be a fatigue. Fatigue and gravity tends to exaggerate asymmetries, that slumping into an asymmetrical position. It could be because of hip angle. Somebody could be going into that position to open up the hip angle for comfort reasons because of pain. Maybe it's a dislocation or a subluxation of the hip joint, and they're trying to open up the hip angle for comfort reasons. And then, of course, any unequal load on the tissues leads to that increased risk of pressure injury as well. And this is the pelvic rotation I mentioned, where one side of the pelvis is more forward than the other. Often tends to happen with that pelvic obliquity, and then because of the nature of the pelvis being at the core, we could then get a full body rotation as well, rotation of the spine, wind sweeping with the knees being pulled over to one side. You could have some intrinsic causes for that, going back to some of those neurological impairments and sensory impairments. But just be mindful as well that some individuals choose to go into this position for functional reasons. So if somebody, for example, has a hemiplegia, they use the unaffected side of foot to propel themselves around the environment. So just be mindful of that. Again, finding out intrinsic, extrinsic causes, seeing what we need to correct or accommodate, not only for posture, but also all those other key objectives as well in terms of their function, independence and their well-being. And the next posture challenge that we come across, I mentioned it briefly then, wind sweeping, very technical term. And this is where you see the external rotation and abduction of one hip and the internal rotation and adduction of the other. It looks as if the wind has just swept the knees over to one side. What can happen is nighttime position is really key for this position, especially individuals if you're working in elderly care, where maybe someone with dementia adopts that typical fetal position at night. If they lack the awareness to change position and they're maintaining then that for 8 to 10 hours at night, how are we then expecting them to be able to extend out into a good sitting position during the day? So we need to be mindful of that wind sweeping. It's not just the lower limbs though, even though it presents as this wind sweeping in the lower limbs, it's actually a whole body system challenge because of the impact it has on the pelvis and the weight of the knees pulling and rotating the rest of the body. So we need to think about that overall pressure injury risk and overall posture deterioration that can come from that rotation, especially the pelvis, the spine and the head. Another spinal challenge we can come across is a scoliosis. So it's where the spine twists and curves to the side. Again, as part of that postural assessment, determining whether that's maybe an S curve or a C curve that's happening, because that will dictate what kind of lateral support and trunk support will be needed on the chair. So the seating assessors would need to know that prior to the assessment, to the joint assessment. What we might see is individuals lean into one side. Maybe you can see in the image there uneven shoulders, so the height of the shoulders is different. We could get that rib protrusion on one side as well. These are really just good key visual signs that a scoliosis might be happening. And then, of course, doing that postural assessment where possible, palpating those spinous processes to determine what kind of curve is happening. And the problem with scoliosis, again, because of it impacting on the pelvis and the spine, and the rotation that can happen, it's associated with all other postural challenges. When we're talking about complex individuals, it's not just going to be one of these postural challenges. We could have a mix of all these different elements. With scoliosis, what we can see is physiological dysfunction as well, because of the distortion that's happening to the organs underneath. Maybe problems with lung volume, with respiration, cardiac efficiency as well, and just being mindful of their health when it comes to scoliosis. There might need to be an MDT approach there to manage that. Next, we have an increased thoracic kyphosis. So these curves on the spine are natural. We all tend to have this natural curve to the spine, but it's when these curves become excessive that it becomes an issue. So with an increased thoracic kyphosis, you can see the thoracic region there is more rounded than normal. Again, another issue with this is that physiological dysfunction because of the distortions happening to the organs, especially eating and drinking as well. So if you're working with complex individuals who might also have dysphagia, they might have problems with safe eating and drinking and swallow function. This can really impact on that because of the inability to achieve a good upright head position. So that's another extra challenge we need to think about when we're addressing all those body segments. This can have a significant impact as well on their interaction and engagement because their eye line might tend to fall to the floor. Just because it is a really fixed posture as well, really difficult for them to bring their eye line up and communicate and interact with people. I'm thinking about sensory impairments, those who rely on lip reading, for example, is how we then manage that and use the chair to try and get periods of interaction for that individual through different chair functions and accessories, and we'll cover that a bit shortly. And then moving on to some of the most difficult, complex presentations that we can come across with contractures. In the simplest of terms, this is just a limitation to the passive joint range of movement. It's multifactorial because a number of different structures can be involved through to the soft tissues, starting off with shortening, for example, at the knees with the hamstrings muscles, and the longer that abnormal, prolonged posture and positioning happens, we could then see involvement of the joints as well and the bony changes. And that's what we're trying to identify and reduce the risk of happening to hopefully stop that becoming irreversible. Now, body distortion isn't inevitable as long as we are identifying risk and considering and determining those individuals and getting the right equipment in at the right time. We can reduce the risk of seeing these really complex individuals and sadly hearing those terms like unseatable. So we need to identify risk, be proactive with that postural care. We might see individuals with especially high tone who can present with risks, especially if they also lack the ability to change position themselves, or lack the communication to convey that they're uncomfortable. If there's no support plan in place to achieve different ranges of movements at the joints, then what we can see is these contractures developing. But remember, there doesn't have to be a neurological impairment. That's not imperative for contracture to develop. Anyone who sits in a prolonged positioning that's abnormal without a regular change of position is at risk of those shortening or those soft tissues. Now, I know we've got some individuals joining us today as well from elderly care, from specialist dementia unit. And when we talk about getting older, there's lots of research, there's lots of different ONS, the Office of National Statistics, that have come out that gives some really interesting data. Now, at age 65, individuals can expect to spend around half of the remaining life expectancy in good health. However, that likelihood of experiencing multiple chronic or complex health conditions increases with age. So as life expectancy increases, sadly, so does the amount of time that those individuals spend in poor health. Now, an individual who lives with a chronic condition will have challenges that persist and will likely have ongoing management over a period of years or even decades. Now, an individual with multiple chronic conditions will, of course, have more complex management needs. Now, it's believed that those aged 60 to 64, 29% of them have 2 or more chronic conditions, and this rises to almost 50% for those aged 75 and over. That's a significant part of the population that might need ongoing support and who might be at risk of postural challenges. Frailty as well, which as we know is characterised by this progressive decline in mental and social functions and of course physical functions. That also becomes more prevalent with age. And now it's staggering from those over 65 around 10%, and as we reach over 90 increases to around 65%. The prevalence rate of dementia among older people in the UK is estimated to now be 7.1%. And coinciding with this is, of course, the social care needs, whether that's formal or informal. And those of you joining from care homes, of course, there's going to be some social care needs there, increases with age. And it's believed that 1 in 5 men and women between 75 and 84 have at least some problems with activities of daily living, such as washing or dressing. And when this gets to age 85 and over, it's at least 34% of men and 42% of women. Now, how does this impact on posture in the older person? Now, the older person can experience generalized weakness. With that can be inactivity and, of course, deconditioning. It doesn't take long to lose those skills and those abilities. And that doesn't have to happen with an associated illness or disability. That can just happen with the effects of old age. That frailty can significantly exacerbate those problems. And then what we can see is poor postural control with that pelvic instability, and especially that posterior pelvic tilt we mentioned, because gravity will take hold. Once gravity takes hold, it traps individuals in those destructive postures, and gravity tends to exaggerate asymmetries. So we also get the postural deformities on top of that unequal loading on tissues, the increased risk of pressure injury as well. What we can see, you can see in the image there, is gravity tends to result in this slumped posture, leaning to one side and even sliding down the chair, and the risks that pose to safety then within the chair. So the $1 million question, why is postural care so important? Well, it's directly related to a person's health, well-being and quality of life. There are going to be physical, psychological, emotional effects of body shape distortion, and sadly severe and life-threatening consequences. So there was a SIPOLD, an inquiry, confidential inquiry into learning disabilities, and what they found that there was inadequacies in postural care, and this had a severe impact on life expectancy and premature death. It's believed that 52% of individuals with a learning disability die prematurely from respiratory related conditions. And as we know, postural care, trunk symmetry can have a major impact on that. So visually, you can see the distortion there that we mentioned on the internal organs, lung volume, the ability to take a deep breath, rounding of the shoulder girdle, even down to digestion, and the impact that that can have on individuals. So if somebody is unable to maintain that upright, symmetrical sitting posture with an upright trunk, research has shown that there's an association with decline in physiological function, which is directly impacting on somebody's health and well-being. What can also happen then is increased risk of infections, increased risk of hospital admissions, and also then being confined to the bed, to the 4 walls of their bedroom. So what we also then have is a limited opportunity for interaction and engagement. Now, as I said, body distortion is not inevitable, and with the right equipment and positioning techniques, we can help to protect body shape. So we need to be proactive with that. And what we need to do is try and maintain this optimum, encourage this optimum sitting posture. I don't necessarily like the term good or bad sitting postures, just because even in complex situations, we might be able to do our best with individuals, and actually it's not necessarily a good posture, but actually it's optimum positioning for them. It's the best that we can achieve to encourage those seating objectives. Those of you who have an interest in postural care will no doubt have heard of POPE, of Pauline Pope, and this is just a really good checklist of things to try and achieve when we're looking at optimum positioning. So visually we can see the difference here. That's gravity taking hold, and what we want to achieve is obviously this gold standard, obviously not achievable in most complex cases, but we should still be aiming for that individual's optimum sitting posture. If we can't correct, then we have to accommodate to reduce the risk of that deterioration continuing. So what is specialist seating? In the simplest of terms, it aims to allow individuals who might otherwise have difficulty to achieve their optimal sitting posture. Now, if somebody cannot sit in standard seating, if they can't maintain their posture for long periods of time, if they are fatiguing quickly, if they're at risk of damaging their body segment, then that's where specialist seating plays a role to enable them to sit out comfortably and safely. So those who have trouble achieving their optimum posture, whether that's through age, illness, disability, disease, we need to think proactively about getting postural care in place. So when we think about those individuals, we break it down into these 4 different categories. Just as a good tip, really, when you're working with individuals, to think about actually, are they at risk of achieving optimum positioning? So we've got those who lack, of course, the physical ability to change position independently. We've got those who experience sensory impairments that affect their awareness of their position. So thinking again about that proprioceptive feedback. Those who lack the cognitive awareness to know that they need to change position. Maybe that's an individual with dementia, for example, who doesn't know they've been sat in the same position for the last 10 hours and they actually are getting uncomfortable and need to change position. And then those who lack the communication skills to convey that they need to change position. Maybe someone with speech impairments or learning disability and they can't actually relay that they're uncomfortable, or the support team are not aware of how they communicate that they might be uncomfortable and they need to change position. So at CareFlex, we've broken it down when we're thinking about the individual, so that's what we're going to focus on first, and then we'll have a look at more the support network side of things. But when we think about the individual and the key principles of seating, for us at CareFlex, the top priority is comfort. And that's strange coming from a physio, but actually that comfort is more important than achieving that perfect posture right now, because comfort is what drives compliance. If the user's not comfortable, then they're just simply not going to use that piece of equipment. I have no chance of achieving my clinical objectives, i.e. the postural aspect, if the user doesn't use that piece of equipment. So comfort is priority. It's subjective, and we have to work with the individual to understand how they might be comfortable, how they communicate that they're uncomfortable, and what their choice might be in terms of when they trial in the different chairs. And then we have posture, of course, postural care and postural support. And we'll have a look at the seating solutions in a bit more detail and see the chairs in action. Pressure, it plays a massive role in postural care because they are inextricably linked. And there's definitely a change, starting to see a change in awareness now, not just putting cushions, thankfully, on top of cushions. We need to actually think about positioning and how that interacts with the pressures that's going through specific body sites. So posture does have an impact on pressure and those pressure points. We need to think about their function. So when we talk about complex disability, when we talk about elderly care and dementia, we need to try and encourage as much functional movement, as much activity and independence as possible, not only for their well-being, because staying active is shown to be important for well-being, but actually to protect the body segments as well, reduce the risk of injury, get blood flow to the areas, get the joints moving through the range of movement to reduce the risk of those contractures and deformities happening. Of course, we want people to be safe. We want them to stay safe within the chair, to remain within the chair, reducing the risk of falls, enabling safe transfers, but also the health aspect as well, keeping people healthy by thinking about their physiological function. And then well-being, because it's really important for a fulfilling life to have interaction and social engagement. And if somebody can't sit out, if they come confined to the 4 walls of their bedroom, we are going to see the effects of loneliness then on their well-being factors. And that's been shown to be one of the biggest links, that loneliness can be twice as harmful as obesity is to physical and mental health. So I thought it would be a good time to introduce Zoe and just run through how specialist seating specifically can help somebody like Zoe. Zoe is a 21-year-old, very sociable lady who enjoys music and photography. She resides at a specialist residential home and attends the college 5 days a week. She has mixed cerebral palsy, moderate learning disabilities, elements of spasticity, but actually because she engages so well with therapy, has good range of movement. As you can see from the image, has good sitting balance too. She's able to still complete standing transfers with assistance of one, but this sofa is the only alternative seating she had at the home. I don't know if you can see in the image there, if it's clear enough, glaringly obvious, feet aren't touching the floor, going into that posterior pelvic tilt, even though she has good sitting balance, fatiguing quite quickly because of that pelvic instability. And of course, the inadequate seating, not supporting her adequately, not being able to sit out for as long as she wanted to because she was getting uncomfortable and fatiguing quickly. So specialist seating then plays its role. You can see the difference there. What we're trying to do is get that more upright sitting position in, opening up the shoulder girdle, getting the feet supported because we naturally seek that proprioceptive feedback through our feet to get that pelvic stability, reducing that sacral sit-in, more of equal loading on the tissues to reduce the risk of pressure injury. So things like adjustable seat depth are really key, and we'll cover that when we have a look at adjustability of chairs. Tilt in space, contoured backs and the head support for that trunk alignment. Flip up adjustable foot plate, really important because of her standing transfers, being safe with those transfers, and making sure that she can get good foot placement for sit to stand to keep enabling that function and activity. The negative angle leg rest, again, to help with that foot placement. And tray was actually really key for Zoe. When we look at the chairs, we can relay some of that information back, and Les can discuss that in a bit more detail. So that's the individual. And as I mentioned at the start of this presentation, there's also key objectives for the support network as well. So by thinking about an individual's postural care and their seated prescription, we can also support the carers, the family members, the support team, thinking about improved safety, reducing that dependency, using functions of the chair to reduce the effort that might be required, improving time management, and long-term goals with cost effectiveness as well. The more complex somebody's presentation is, the more management needs they have, and the cost goes up. So if we can be proactive, get the right equipment at the right time, and keep people's presentations out of the complexities, then we can reduce costs as well. The specialist seating, this is what we're going to focus on now, is have a look at the chairs, the seating solutions, and think about how we can support the support network as well through adjustability, usability of the chair, reliability and durability, pressure care, of course, and infection prevention and control, which is a really key part of that pathway for multi-user environments. Hopefully we should be back on screen.
Okay, thanks, Rebecca.
A lot of information there to get through.
Just a little bit. So what I thought I'd do to start with, before I look at a chair in particular, is just related to Zoe's story. So Zoe's story started with a request for a seating assessment. From that, we took the key bits of information that Rebecca's just run through to establish Zoe's clinical need and requirement for specialist seating. So the process starts with that telephone call. We then take that call and we kind of match, if you like, the most appropriate chair to meet Zoe's needs. So part of the assessment, it is it's like a personalised assessment where one of our seating assessors visited Zoe with a range of chairs to see which would be the most appropriate for Zoe. But that initial call had to narrow it down to one in particular. Key for Zoe was energy management and comfort. Tilt and space really ties into that. Adjustability, we needed adjustable seat width and seat depth adjustment. All the chairs have that capability. We try to keep things as simple as possible as well. We try to go for the least complex intervention as long as it's effective. So the chair to my left here is a chair called the Smart Seat Pro 2. Very adjustable, very configurable, seat width, seat depth, tilt and space, back angle, recline. I can go into a little bit more depth with this chair in a little while, but it was overly complex for Zoe's needs. And we're quite keen, I quite often talk about the holistic seating assessment. So The standard requirements that we need to know for a seating assessment are seat width or hip width, seat depth, standing transfers or fully hoisted transfers. But we also need to know a little bit about the environment, and bearing in mind Zoe's environment, the carer input is really key. So we like to keep that solution as simple as possible. The less complex, the less there is to go wrong. So that brought us to either the blue chair to my right or the grey chair, the multi-adjust or the hydro tilt. Could have been either chair really, but again, key for our consideration here was comfort, and comfort was better for Zoe in the hydro tilt chair. Plus, going back to my theme about overcomplicating a product, the multi-adjust, as well as having tilt in space, has back angle recline.
It's probably a good opportunity to cover actually tilt and space and back angle recline here, because when we talk about usability of the chairs, and as Les said, not over prescribing and making sure that we consider the support network and the care plan. If a function isn't needed, then simply don't supply it, or find ways to lock off that function. So tilt in space, a fantastic option, because it's posture neutral, so it doesn't affect those critical angles for sitting. And most of the things we can achieve from back angle recline, we can actually achieve from tilt in space, energy management, pressure redistribution. But the difference is the back angle recline opens up the hip angle, and if it's used inappropriately, if somebody lacks that pelvic stability, we can actually see tone and reflexes shoot through the roof. We can see that extensor thrust, we can see a posterior pelvic tilt, and sliding down the chair. So we could actually cause some of these postural challenges that we're trying to avoid by using back angle recline. So where possible, as long as suitable, tilt in space. When I send out the presentation, there'll be a lot more detail on the slides, because there are certain cases where tilt in space isn't going to be appropriate for individuals thinking about dysphagia, catheter use, those who you need trays for PEC systems and so on. But there'll be a bit more detail in the presentation, because we just haven't got the time, sadly, to run through everything today. But tilt and space, that's the difference between tilt and space, back angle recline.
So back angle recline, although it's an additional feature on the multi-adjust, is something that Zoe didn't need, so we discounted that chair.
She had good hip range of movement, yeah, so she didn't need that back angle.
Plus, we could try the chair, it came under comfort, and Zoe just found the hydro tilt that much more comfortable. We could see from the picture that the sitting balance was pretty good. She just suffered from fatiguing as the day went on, as she came home from a busy day in college. Sitting on the settee that you saw, she just slipped to one side or slipped down the chair, spending more and more time in bed. So tilt and space helped with that. As we've already said, posture neutral, that back to hip angle remains constant. Seat width and the seat depth on the chair can be adjusted as well. We adjust the seat width by changing what we call a saddle arm. So I just put a thinner or thicker arm on the chair to increase or decrease the seat width.
And seat width and seat depth, when we talk about the basic chair dimensions, that should be always the starting point for chair setup, because it's probably one of those steps that often gets overlooked, maybe especially in multi-use environments, when you've got a 6-foot gentleman and a 5-foot lady using the same piece of equipment. But that adjustability, and that's where specialist seating comes in, to be able to do seat depth and seat width is really critical. Because I mean, should we show them even for me?
Seat depth?
Yeah, we'll show seat depth.
I'm going to use seat depth on the multi-adjust because it's just an easier chair to demonstrate. I can take the arm away from the chair as well.
So when we talk, I don't have any damage to my body systems, but if we don't have something as simple as the seat depth set up correctly and individualized to the person, then we can actually cause those postural challenges.
Jump in the chair. I'm just going to show you how I adjust the seat depth. Okay, I'm just going to turn this to you. So there's a little lever here which I hold and press down. It's very similar across the chair range. There's slight differences, but this is basically how we adjust the seat depth on a chair. So I hold this lever down, and I press, push the back in over the seat surface to decrease or increase the seat depth. So that's going to be where we're going to start, Rebecca. Yeah. Just to show you what happens if the seat depth is too short.
So we have about 75% of our body weight going through our buttocks and thighs. So if the seat depth is inappropriate, then we've suddenly got half of that not taking the weight distribution. So we can have even more pressure going through the pelvis, going through the ischial tuberosities or even the sacrum. So that's why it's important we get the seat depth right for pressure care. And then on the flip side of that, if something is too long,
something we see a lot of is the seat depth being too long. Especially
with kind of these standard high back armchairs. Now seat depth is too long for me. You can see my feet dangling there, just to be able to flex my knees, because it's not very comfortable having that digging into the back. Just to be able to bend my knees over, I have to go into that sacral sit-in. So I don't have any damage from body systems. By something as simple as a seat depth, I created that sacral sit-in. So that posterior pelvic tilt and all those associated significant problems that comes with that, we've just created it from having inappropriate seat dimensions. And then likewise, what can add further to that is no foot support. We saw in the image of Zoe in her on her sofa. That's her only alternative seating. To be able to get her feet on the floor, we naturally seek that proprioceptive feedback through our feet. We're going to cause even more of that sliding with risks to safety then as well, just to get the feet on the floor. And then what we might see is individuals clinging onto arms, digging elbows into corners to get that pelvic stability, because they're just not getting that sensory feedback that they need. The same as seat width as well. If the seat is too wide, what we might see is a rotation within the chair, that pelvic rotation, because we naturally seek that support. Yeah, we naturally seek that support, and what we might see, because I'm just feeling unstable in the chair, I get that rotation because I want my hips to dig in. I want to feel the chair around me, and we're causing again that challenge, that significant postural challenge. So don't forget that step, those basic seat dimensions.
So seat width and seat depth. We didn't need an elaborate lateral support system for Zoe. Her sitting balance was quite good, as you can see from the picture. We didn't need anything as complex as we see here on the SmartSeat Pro 2. Each of these sections adjusts individually, so we can bring a head section forward, we can twist, we can rotate, we can lengthen. Where we're working with somebody with a fixed posture, we can bring the support surface out to accommodate that posture, to prevent further decline. On the Hydra Tilt, very simple shaped contoured plaque, and this just prompts Zoe to sit in that midline position.
Yes, that fine balance between offering support but still encouraging that active engagement. So we don't want to de-skill people either. We don't want to fully support someone so they lose that ability. So it's that fine balance between how much energy management is needed, how much prompting is needed, and that's why that contour is good, because it's still Zoe still has to engage her core to stay upright. But when she starts to drift, it just prompts back to that midline.
There still is a little bit of adjustability. The back of the chair comes with the foam lozenges, which can be moved around. We didn't need to do that with Zoe, but we may be looking at these chairs today with me here and with me and Rebecca here. I think I've got a chair like that in my home. It's not being used at the moment, but the back that's on the chair that Les shows me would work really, really well with the chair that we have. So you could reissue or reuse that chair with another resident.
When we think about that cost saving as well, recyclability.
Yeah, recyclability is key, especially in a care home setting. Just to point out that the chair is designed to be reissued, designed to be recycled. They're very modular in design. But for example, if you're thinking this chair that you have in your home there, maybe the seat width may be a little bit too wide, we can make the seat width narrower. If you want to make a note of the serial number that you'll find on the back of a CareFlex chair, the silver label, just here. And every chair that we've ever made has a unique serial number. They're Class 1 medical devices. What it means for you, as well as kind of underpinning the quality that we design and produce products to, means that we can tell you what the exact specification of this chair is. So we can tell you what the seat width is. We can tell you what the capabilities are for seat depth adjustment. We could work out really whether or not it has the capability to be adjusted or to be adapted to the needs of your new resident. So it's a recyclable product, and it's really important to understand the importance of and the relevance of this serial number there. Again, coming back to recyclability, we've not mentioned aesthetics really,
No.
Zoe, but aesthetics can be a key thing for certain individuals.
Yeah, it's one thing we always ask on our training days, what people think is aesthetics a luxury or is it a necessity? And certainly when we work in with some complex individuals, maybe working with autism spectrum disorder, dementia, where there might be an affinity with a particular colour or texture or familiarity, visual impairments, again, is the aesthetics, as long as we can clinically justify that, sometimes is actually key to compliance.
And again, you'll see, perhaps Jess will post the link. There's a wide range of colours that we can use with the chairs, but if the colour is key, it may be a barrier to perhaps using that chair with somebody else. Perhaps somebody doesn't like blue, somebody likes red and has a really strong desire not to sit in a blue chair. All the covers on a CareFlex chair are loose. So if I don't like blue, if I'm not an Everton supporter, perhaps I'm a Man United supporter, or perhaps I want a red chair, we can simply peel the covers off and they can be replaced. They don't have to come back to us to be recovered. We can do that on site. Again, the important piece of information we need, choice of the colour, plus that serial number on the back of the chair. Talking of covers, these are antimicrobial, so they don't support the growth of bacteria. Again, a key consideration in a care setting. Yeah,
that infection prevention control, as we said, a key part of that pathway sometimes. So that patient journey, especially multi-user environments, being able to safely decontaminate and clean. Les said about it being modular, being able to take parts off to clean into the certain areas, the four-way stretch as well, being breathable and permeable to help with pressure care as well. That choice of fabric, yeah, is really key.
So key consideration for Zoe was the leg rest and the foot plate, and we often find that it's the small detail that makes a big difference in the use of a chair.
Yeah, I think
so
somebody
stand transfer was key for Zoe.
I think somebody just asked about the stand and transfer.
Right.
Yeah,
and that was key because we want to maintain function. We want to maintain that ability. Really, the foot plate and the leg rest, or the foot plate in particular, is designed with those clients with a contracture, with a limited range at the knee. But the other advantage is that if you do have a stand transfer, I just try to position the chair so you can see what the brake's on. So we can use the foot plate and leg rest as is, because we need to provide support for the foot. When she comes to transfer out of the chair, we can flip the foot plate up. We can retract the leg rest into a negative angle. So it just gives Zoe just that nice angle there to plant and just to drive up the chair. You see the wooden knuckles on the chair, you come in handy for this as well. And it was the seat depth, or the seat height, sorry, was just at the appropriate height for Zoe.
Yeah, that foot placement really key for that base of that centre of gravity within the base of support to be able to propel herself forward and to help, because she did have a systems of one. So when we think about the support network as well, reducing that dependency, reducing the effort that's needed by the carer as well, be able to support that, so reducing the risk of injury and reducing that dependency, as we said.
And I'm just coming back perhaps to the carer input. We went for a manual chair, controlled off one lever at the back of the chair. Just squeeze the lever, adjust and release wherever it's most appropriate for your resident or for whatever Zoe found most comfortable.
Yeah.
We do powered versions of the chairs as well, which gives the independence to the person sitting in the chair, or helps a carer perhaps provide care by having that powered option on the chair.
Yeah, we mentioned about the support network for Zoe. Fantastic that she was still able to actively engage in those transfers. But if you work with individuals who are hoist transferred and tilt and space is appropriate, that can be a really key function for positioning, especially for care teams, to reduce that effort. So if you engage a slight tilt, we can utilise gravity during hoisting to pull the pelvis into the bottom of into the back of the chair to try and get the positioning and the pelvic stability right the first time, rather than seeing individuals trying to pull slings and pull individuals into the back of the chair. Utilise gravity where possible. That tilt in space can be a really key part, as well as coming in from the side. That tends to work really well with specialist seating.
And coming back to the process that I started with to describe how we provided a chair for Zoe, I mean, up until now, I've discussed all the features and benefits of that we identified during the assessment. The key component, the key final component, is the delivery and setup. So our products would be delivered and set up by our own seating assessor. We make sure that the detail and the finesse of the final adjustment is just right for the client who sits in the chair, because it's the little things that make a big, big difference. We also believe strongly in training. That's why we're here today. But as part of that setup process, there's an informal training session where our seating assessor would explain to carers and staff how the chair works and what are the key things to consider when using that chair for a resident. It doesn't just stop there. Things do change, and quite often we get involved in reviews and auditing seating at care homes as well. So there's an ongoing relationship that we have with our customers. That's Zoe, that's the HydroTilt. One thing to mention as well is pressure care. All the products of pressure care cushions is standard. It's what we call water cell technology. It's rated medium to high. It's a combination of 3 water cells, a memory foam, and the 4-way stretch breathable fabric that you have on the chair. What happens is the high pressure point becomes my teeth back in. The bony prominence comes into contact with the chair. The 4-way stretch gives and absorbs that bony prominence. The surrounding surface, the water, displaces, rises, and spreads the pressure over a greater area. But I'm just talking there about the seat surface. We look at the product, the chair, as a pressure care system, and we are trying to marry posture, pressure care, and the movement of the chair as well. The setup of the chair. It's not just the surface you're sitting on, it's how you sit on that surface and how we manage to get as much of the client in as possible in contact with the chair. Yeah, in the simplest terms, when it comes to pressure care, that's what it is. It's getting as much of them in contact with the chair as possible, equal weight distribution, supporting them over the maximum surface area, and utilising the whole seating system to do with that. We mentioned about tilting space, that could be really good for pressure care as well. Different research says that different degrees, that we start getting to 15 degrees of tilt, we start seeing pressure move away from the pelvis, and then more towards 20-25 degrees tilt to really disperse that away from the ischial tuberosities. And to help with that movement side of things, we have an option called auto tilt, which is a regulated motion. So you press the button on a handset and the chair will slowly move through its range of tilt in space. Yeah. For Zoe, that was it, but I think it's probably worth, I mean, we mentioned quite a few postural challenges, so I don't know whether it's worth just having a look at maybe some of the solutions for kyphosis. More complex seating, because when we talk about kyphosis, scoliosis and wind sweeping, it might be worth just showing some of those seating solutions. I mean, on a HydroTilt, we may look to accommodate that kyphosis with this soft profile headrest, just very softly envelops the spinal shape comfortably, but just provides that little bit of support as well. Perhaps we're going for a kyphosis, we may think of a waterfall back. Now a waterfall back, I have one here for the HydroTilt, just a series of 3 sacks of Dacron, a fibrous material which is very soft and again accommodates that spinal profile. Yeah, to be careful that we give lateral support there as well. Yeah, so when we saw that image of the gentleman on the lateral view, and you can see really see that rounded part of the thoracic region, manipulating and modifying some of that filling to really encompass it. So we can't correct the individual, but we can encompass it as much as possible. And then up from that then would be obviously the SmartSeat Pro 2 when we talk about really fixed postures. And as well scoliosis, really complex fixed deformities where we can't correct the individual to the chair, so we need to bring the chair to the individual. So again, a tilted space chair with back angle recline, built-in seat depth adjustment, very similar to what I showed you on the multi-adjust, angle adjustable foot plate, elevating leg rest, and again a negative angle on the leg rest as standard. Here taking us to brakes on. Taking us to a minus 25 degree angle. But just to focus on the back sections, 4-section multi-adjustable back. Each section can be adjusted and moved in a very similar manner. Little flip out fastening mechanism here, which I just loosen off. So if I have my kyphotic client, bearing in mind I'd be adjusting each section of the back as well. Perhaps a fixed posture, maybe needing to angle top sections.
And even offsetting as well for that scoliosis.
Smaller client, as Rebecca just said, perhaps somebody with scoliosis, I can just loosen that there. If I just spin that round for you, or I can just move that back. Oh, we've got that lateral adjustment in it as well. The wings can be adjusted. You notice I'm not using any tools for this.
So when we talk about usability as well, thinking about the carers or even therapy teams who might need to use it in rehab settings, between users being able to adjust all these adjustments and be intuitive with those adjustments and tool free, as Les said.
Down the top section as well will dip. So if we marry up the adjustable sections of the chair with perhaps a soft profile headrest, see the contouring I'm starting to build up into the back of this chair.
It's really bridging that gap between somebody needing moulded seating but still the flexibility and comfort that comes with this, especially if we're hoping, because in some cases we can actually restore body shape distortion as well, and having that flexibility to manipulate the chair around the individual as hopefully things improve, or sadly if things deteriorate as well, that long-term support, not needing to issue a new chair if needs do change, and the cost saving that comes with that.
I think we're just about drawn to an end, and perhaps it may be a good time to open up to some questions. Jess, do you have any questions for us there on?
Yes, so we actually have a case, so I'll read through it, and if you're able to provide any advice or your opinions. So this person has a client with ABI left side affected and defaults with a push towards her left. She has a severe cognitive impairment and will not / cannot, for the most part, adhere to follow simple instructions and is not aware for the need to self-correct her posture. Movements are erratic and sudden and, on their terms, therefore not static to hold a fixed posture. They find that comfort and short sit-outs on a respective specialist chair is the only means of support. Your thoughts would be appreciated.
I mean, that's the compromise there, isn't it? So that's the magic word, that we can only really do what we can do. I mean, if somebody's really active, then that's less of a risk than somebody who's maintaining prolonged static.
Were they fully hosted, or was it a stand transfer to the?
That's not mentioned, actually.
And the posture, was it fixed? I didn't quite catch whether or not it was fixed. There's an awful lot of detail.
Yeah, so it's not static to hold a fixed posture.
If there's something, I'm more than happy to probably have to go into a lot more detail to find a bit more information. So if we take the contact details, Jess, and we can follow it up with just more of a in-depth 2-to-1 session. Yeah. Because there's probably a lot of questions there that we need to figure out.
Yeah, absolutely. They did say that it was a SARA steady transfer and it's not a fixed posture.
Okay.
All right, so I guess partly from what I'm hearing there, then we're looking at the sudden movements, the sudden uncontrolled movements, something that needs to be strong, robust. Again, a little bit of a compromise. If you're going to use the product as complex as a pro, there's an awful lot to go wrong.
Yeah.
I may be wrong, but I'm thinking of something along the lines of a hydrotilt.
Yeah, if the critical angles are okay, if there's no limitations to hip range, there's something robust without a back angle recline, and if possible using tilt for some pelvic stability, and then obviously least restricted moving up, then you could trial then ramped bases, console cushions, even up to positioning aids. Is that something that can help? Because then that proprioceptive feedback with positioning aids, as long as they risk assess appropriately, can sometimes help to dampen down some of those movements as well.
That seat to floor height would be a crucial thing for us to know as well. I kind of think of the hydrotilt because it kind of really suits two categories of clients at either end of the robustness spectrum. One is that frail and elderly individual with that prompted midline posture that we get from the back there. People tend to find it very comfortable. The other option, or the other kind of client group, is perhaps that heavier user. So I'm thinking of somebody perhaps with Huntington's, semi-ambulant, with a very kind of uncontrolled transfer into the chair. The chair is very strong. It's very, very robust because of the design of the chair. So I don't know if that helps, but I'd be looking potentially at hydro tilt.
Yeah, and then just working our way through the pelvic stability, I think, is the biggest thing here. Working our way through the least restrictive options to see where their tilt ramp base, working our way up to position aids is something that could help to stabilise some of those movements.
Perhaps even a ramped cushion, possibly. So this is everything we've shown you today is a standard component, an off-the-shelf component. This is a custom-made product. So just perhaps providing that well for somebody to sit back into may help to support and prevent that slide and that slip forward as well. So you've got the 75mm ramp at the front edge, just that shape across the front there with a hint of a pommel, if you like, built into the cushion. So there's lots of potential solution.
If we take contact details, we can discuss it and ask some of those pertinent questions and see, and maybe even get a chair trial in place to see whether it does help.
Anything else, Jess?
Brilliant. With seat height, are all the chairs adjustable for their seat height?
Not all the chairs, no. So the multi-adjust, as is at the moment, this is a medium frame chair. It's a fixed seat height. Hydro tilt comes in a range of different frame sizes. So depending on the individual, we've got a mini, a small, a medium, which is a 21-inch seat height, an extra wide and an extra large chair, again 21-inch seat heights. The Smart Seat Pro 2 has 4 different seat heights and they're all built into the chair. So if I just show you. There's a slight technical adjustment that we need to do with the chair, but there's a series of bolts here which we take out and we can adjust the height of that chair for the individual. So I was working the other week with a client who was 6'4", quite a tall individual. We knew that in advance, so we set the chair to the highest seat to floor height to start with.
Thanks, Les. There was also, so for people who may be shorter, there was some concern about the shorter seat height causing issues with the caster wheels. Do you have any advice on that?
We tend to use a smaller caster on a smaller frame chair. We will also be shortly be launching smaller versions of the multi-adjust, which will have adjustable seat height. But part of the design process, if you can see that, what happens with a lot of specialist seating products is sometimes the footplate will clash with the caster as the caster swivels. And if you can see the caster swiveling down the floor, but we very design of the chairs takes that into account, so we always make sure that there's enough space for that caster not to catch on the footplate or the leg rest. Not sure if that answers that question.
That's great, thank you, Les. I believe that is all of our questions for today. Right,
okay. Just, I guess, before we finish, just a couple of things to run through in which ways we can provide you with more support and more help.
Now there isn't enough time to get through all our information.
Of course.
The presentation that we do send out from today will have a lot more detail on it, so I'll put a bit more information there about specific conditions as well, about some of the chairs, some ideas and top tips around that might just help guide you.
So the website is full of really useful clinical insight from Rebecca. We've clinical guides, we've product guides, clinical evaluations and assessment guides. We've also got, this is written by Rebecca, the Encyclopedia of Specialist Seating. If you just want to drop us an email, just to say if you'd like a copy. Plus, we do either PDF or the old-fashioned paper versions of this, which is the Clinician's Pocket Book of Seating. So there's a whole range of clinical support available if you just check on the website.
Yeah, I think we mentioned about the YouTube channel as well. Lots of
YouTube channel. Yeah. Plus, if you, we did mention about, you may well have a hydro tilt or a multi-adjust or Pro or one of the other chairs from our range. you're not quite sure how that works or how to adjust it, give us a call with a serial number. Or again, you could go to the website where we've got these how-to videos, and it'll explain to you in a lot of detail some of the adjustments I've been making on the chair this afternoon.
Yeah, we've got lots of stuff as well we've developed for family members, specifically taking some of the jargon out. So if you're working with family members or care teams where you want less of a clinical approach and more about the benefits and the holistic approach of seating, we've got relatives brochures as well that might be helpful to share with individuals and their families. So
if we don't have any further questions, I'd like to thank you for attending this afternoon. We're here to help. If you need to get in touch with us, it's training@careflex.co.uk. Thank you, and catch up with you all soon. Thank you. Bye-bye.
Thank you very much.
Bye.